Good morning. Can you hear me?
Yeah,
Yes,
we hear you.
Okay,
morning.
thank you. Okay, so um, today we will start the renal disease, huge topic, and actually the first part will be about the acute kidney diseases. I try to make it full screen, but I don't know, it doesn't really work. Anyway. Oh, I cannot. Okay. So sorry, then I cannot make it full screen, but maybe you can still see it. I got some. Yeah, the slides will be uploaded later. Sorry, it's just I was just finished with the slides after midnight. So and I cannot upload it. So I have to send it to someone who will upload on the system because I have no access to upload. Okay, so guys, let's start with acute kidney diseases and basically um, the importance of the kidney disease altogether, whether it's chronic or acute, is about the epidemiology and the global mortality. So actually, you can see here that, of course, a lot of countries do not really send data to the WHO, but those countries where we know exactly the amount of patients, you can see clearly that the kidney disease related mortality is very significant, can be up to 2.5 or in some countries even a little bit higher percent among all the mortalities. And this is basically due to several reasons. Um, the kidney is a very, very important organ, as you know, and it's very vulnerable as well. Uh, Now we will talk about acute kidney disease, so the acute renal failure, and next week about the chronic kidney disease. But basically, chronic kidney disease in some cases are preceded by acute kidney injury. So basically, one or several acute kidney injury episodes can on the long term uh, lead to chronic renal failure, chronic kidney disease, which needs renal replacement therapy. And that's another problem that we will talk one week later. If you remember from anatomy, actually, and physiology, and all together, try to put everything together here, the kidney has two major anatomical parts, the medulla and the cortex, and actually both are very important. And during the acute kidney injury, both can be injured quite severely. And another issue that we have to remember is that along the nephron, if you take the trajectory of the tubular system along the nephron from the cortex towards the medulla, there is a change in osmolarity, in osmotic concentration, as well. There is a change in oxygen availability, the oxygen saturation. The more deeper you go into the medulla, the less oxygen saturation or oxygen availability you can see. And at the same time, the osmotic concentration increases. And this is a very important um, feature of the kidney because uh, you probably remember from shock related stuff that one of the most important shock organs is the kidney. The kidney is very sensitive to hypoxia and to also other detrimental factors, injuries kind of, that can reversibly or irreversibly harm the tubular system. And basically, this lower internal oxygen availability does not really help the recovery of the kidney after a severe injury. So that has to be remembered. And also, mostly not today, but next week we will talk about the glomerular damages because most of the CKDs are related to glomerular damages. But today also there will be some glomerular issues. In the glomerulus, what you have to remember is that it's a very very complex structure where the filtration takes place. And during the filtration, the unit, the kind of like a filtration unit, which does the job, is the filtration barrier, which is basically composed by three very important filtration layers. One of the layer from the blood side is the fenestrated endothelial cells. Of course, these endothelial pores are not like holes. I mean, it's filled with some structural proteins. So it's not really a very um, allowing everything to go through it. So it's not like an empty hole. The glomerular basement membrane is also very important. It's first of all, it's negative load, negative charge impedes actually most of the proteins to go through, but also the structure of the basement membrane allows or blocks basically the kind of like filtration of macromolecules, um, as long as the basement membrane structure is healthy, is normal. If the basement membrane gets injured and the structure gets compromised, basically it will allow to go, it will allow macromolecules or even larger cells to go through this filtration barrier, and you will see that in later in more severe diseases. And the other end of the or the third layer of the filtration barrier is composed by the podocyte food processes and the slit diaphragm, which is also composed by podocyte proteins that develop a zipper-like structure here, which basically is another filtration barrier. As soon as podocytes get injured or the podocytes are feeling bad, kind of, this three diaphragmal structure will be destroyed, or at least there will be leaks in it, which will allow, for example, proteins freely to go through. And actually, the uh, one of the most important signs of and earliest signs of a podocyte injury or glomerular filtration barrier injury in total is the appearance of proteinuria, so massive protein leakage through this filtration barrier. Okay, so that's basically we will talk about this more next week. Well, just a little bit of summary about the functions of the kidney that you probably remember: regulation of the water electrolyte homeostasis by total body water components, the content, sorry, serum sodium and total body potassium amount, or blood pressure. And the blood pressure regulation is one of the most important due to the renin-angiotensin-aldosterone system. Detoxification of the body, because basically against, for example, acidosis, the kidneys are the most important buffer producing organs, because kidneys can reabsorb a vast amount of bicarbonate in the proximal tubular cells and at the same time secrete a lot of protons in the distal tubules, uh, which means if this function is deteriorated due to some tubular damage, the effect will be immediately an imbalance of the acid-base homeostasis, favoring acidosis. Of course, there are a lot of other substances which are excreted through the kidneys besides the liver, like the bilirubin metabolites, products of protein degradation or nucleic acid degradation, etc. But also, very importantly, the kidney has biosynthetic, very important biosynthetic capacity. And if you remember from last semester, the activation of the vitamin D takes place in the kidney, erythropoietin is produced in the kidney, and of course, renin, which, well, it's connected to the blood pressure regulation. Um, which are the parameters which can show us that there is a decreased kidney function. Basically, these are the so-called retention parameters. These are called retention parameters because when the serum level of these metabolites or electrolytes increase in the in the body, it means that the clearance of these substances is decreased in the kidneys. So there is a lower kidney function or a decrease in the kidney function. Urea, and serum creatinine is the most commonly used two parameters which have their um, drawbacks, some very significant drawbacks. I will talk about this later, especially in acute kidney failure. And serum potassium is also very important because you know that increase in serum potassium very soon will affect the cardiac function, and this can be very dangerous. Um, how can we define an acute kidney disease? Um, Actually, uh, we base the definition on the kidney function measurements. And actually, this kidney function measurement, I will show you later that what are the drawbacks of this. Say that it's either a 50% increase in the serum creatinine within 7 days, or more than 26.7 micromoles or zero point 0.3 milligrams per deciliter increase of the serum creatinine within 2 days. Sorry, that's a G extra here. So within 2 days. The problem is that actually in the first day after an injury to the kidneys, there will be no increase in serum creatinine. So I will show you later that basically the therapeutic window of an acute renal failure, the first few hours up to 12 hours basically, where you would have a very good chance to decrease the kidney damage, is unseen because all the parameters that we routinely check for the definition of acute kidney disease are still in normal levels. So that's a huge problem with these diagnostic criteria. Another diagnostic criteria is the presence of oliguria or anuria. But actually, an acute kidney disease can also lead to polyuria, which means that if the tubular system is so much damaged that the tubules cannot reabsorb sodium, of course, then water will be also not reabsorbed, and this will lead to polyuria. But this is also what we can see in a resolution phase of an acute kidney disease. And there are also some urinary markers of tubular injury that we will discuss a little bit later. How to stage an acute kidney disease? Actually, there are two systems available for staging. The so-called rifle, but it doesn't have anything to do with guns. It's just a mnemonic from the definition of it, and the so-called AKIN or AKIN classification, which basically focuses more in really an acute kidney disease staging. The rifle takes basically into account the long-term complications as well, because here you can see that there will be also the common consequence defined, the total loss of kidney function and the end-stage kidney disease. These are basically mostly non-reversible. I mean, the loss of kidney disease here, loss of kidney function here for more than 4 weeks is already kind of like end stage problem. So it's non-reversible. And of course, end stage kidney disease is also irreversible. It needs renal replacement therapy, hemodialysis, or kidney transplantation. Um, what are the possible complications? So I talked a lot about chronic kidney disease. So there is, I guess, no surprise that this is one of the major complications. Even after a complete remission of the acute kidney disease, several years later, a CKD can develop. And actually, up to 45% of CKD patients have a positive AKD history. So it means that one single episode of kidney injury that leads to acute kidney disease can, on the long term, slowly induce chronic deterioration of the kidney function. Of course, there is also a worse scenario when there is no remission, and this needs immediate hemodialysis, and of course, increased mortality can be also seen. So the cause of the renal failure could be either this acute or the chronic, but the main symptoms are overlapping. And actually, these main symptoms usually are the massive proteinuria. And this proteinuria can be also divided into subgroups, like what is the source of the proteins. Either microproteins from tubular defects, because if there is a tubular injury, the tiny filtrated proteins that can freely go through the filtration barrier, which are like smaller than 30 kilodalton usually. So it's very, very small proteins. They are 100% reabsorbed in the proximal tubules normally. But if the proximal tubules are injured, you will not see any kind of reabsorption. So these microproteins will appear in the urine. It's called microproteinuria because it's the size of the proteins is small, of course. There is another possibility that the glomerular basement membrane and the podocytes are so injured that albumin can go through in large amounts. So this is the so-called glomerular selective albuminuria. That's what we typically see in nephrotic syndrome, and that's more typical for chronic kidney diseases. So we will talk more in detail about this next week. And in cases of the complete destruction of the filtration barrier, when the glomerular basement membrane structure is also destroyed, then we will see even large proteins to go through. And this is the non-selective proteinuria, when from small to large proteins, everything can go through the filtration barrier and appears in the urine. This is typically seen in glomerulonephritis when the basement membrane structure is destroyed due to immunocomplex deposition and inflammation, so local glomerular inflammation. Another feature of this total destruction of the filtration barrier and deterioration of the basement membrane is the appearance of so-called glomerular hematuria. Glomerular hematuria, I will show you a picture later, uh, means that the red blood cells can go through the filtration barrier. But of course, compared to the size of the red blood cells, and of course, if you remember, the red blood cells are very flexible, so they can bend basically, kind of like in half. Um, Even if they bend in half and they reach a 4 micron size, they will have to pass through the although destroyed basement membrane, but still there are the fibers, the connective tissue in the basement membrane. So due to the pressure, these red blood cells will get damaged, and we will see a lot of damaged, kind of like so-called dysmorphic, so changed in morphology, dysmorphic red blood cells in the urine. This is the so-called glomerular hematuria. It's a kind of automatic sign of a glomerulonephritis, so that there is an inflammation of the glomerular basement membrane, which allows the red blood cells to go through. But of course, hematuria can also be a consequence of lower urinary tract infections, if you remember, or lower urinary tract damage, or even malignancies, a tumor which is growing and is bleeding. But the non-glomerular hematuria always shows isomorphic normal red blood cells. So this is the most important difference between a glomerular, so-called glomerulonephritis mediated hematuria and another cause of hematuria, that in the glomerulonephritis hematuria, the red blood cells are damaged. Their shape, size is different. Um, and if you see that in the microscope of a urine sample, automatically you have to know that this is a glomerulonephritis. Okay, so that's the take-home message from here. And of course, there is also a possibility for pyuria in case of bacterial or fungal infections. That's not really what we see in acute kidney disease most of the time, except of pyelonephritis, but pyelonephritis can damage both the tubular and the glomerular system. And of course, edema. Edema will develop due to the protein loss. And this edema can present in a periorbital region. This can present as ascites, and also in the lower limbs, you can see that there can be very small. So this is the so-called generalized edema, and generalized edema is a typical sign of, massive proteinuria, so kidney disease. So what are the acute kidney disease causes, the most common causes? We talked a lot about glomerular injuries already, but the tubular injury has to be remembered as the most common cause, because the tubular cells are very, very sensitive. The tubular epithelial cells, uh, we can say that in the whole tubular system are quite sensitive, but there are exceptionally sensitive parts, like for example the proximal tubular cells, which need a lot of energy. I mean, the proximal tubular cells have to reabsorb most of the stuff that was um, filtrated in the glomerulus, but should remain in the body. That should not be excreted, like amino acids, proteins, bicarbonate, etc., etc., etc. A lot of stuff, and many of these reabsorptions have to go against the concentration gradient, because of course the concentration in the tissue is much higher, which means that it needs ATP and a lot of energy. That's why in case of a hypoxia, chronic hypoxia, the first part of the kidney which gets injured is the proximal tubular compartment. And this is what we see as a shock kidney as well, if you remember. This is the so-called pre-renal cause or hyperperfusion mediated kidney injury. But of course, renal structural that deterioration can happen as well, which is called intrarenal acute renal failure. And of course, postrenal is also possible if there is a complete urinary tract obstruction, which can happen in case of a ureter tumor, or very rarely, theoretically, a stone, a kidney stone, gets intercalated in the ureter and completely obstructs the ureter. But that's a very rare condition. Um, and most of the glomerular injuries that we talked about in the previous slide, which lead to the inflammation of the glomerulus and therefore the complete destruction of the filtration barrier, are immune related, and these we can say are autoimmune diseases. Um, Even the post-streptococcal pneumonitis, which is in adults not so common, it can be related to systemic autoimmune diseases, for example, SLE, for example, rheumatoid arthritis, or some more kidney specific ones like the IgA nephropathy or Goodpasture syndrome, etc., etc. So there are a lot of these causes. The common feature is autoimmune disease. And this is why the treatment of these glomerulonephritis cases is not very different. So mostly we need to immunosuppress a patient. What is the epidemiology of the acute kidney diseases? So you can see that it's quite common. In total, in the complete population is 0.1%. uh, up to 7% in all the hospitalized patients, but it happens up to 1/3 in intensive care unit patients. So basically, of course, patients with severe conditions have much higher risk to develop acute kidney disease. And the causes are very different. First of all, overall increase in age of the complete population. So we have more elderly patients, they have higher chance to develop acute kidney injury. Of course, related somewhat to this, the increased cardiovascular and diabetic morbidity overall in the population. So more and more diabetic patients can be seen, more and more cardiovascular patients can be seen, and acute kidney disease risk is much more increased in patients with comorbidities. So in patients who have several different other diseases at the same time. The more comorbidity have someone, the higher the risk for acute kidney disease to develop if some injury comes to the kidney. There are, however, um, causes that we can influence. So like, for example, the hyperperfusion we can do against it. So in case of shock, uh, we can try to increase the blood volume of the patient. The renal artery stenosis, we have to diagnose it very early. We have to surgically treat it. um, Transplantation, for example, septicemia. These are influenceable causes, and as well as one of the most important tubular injury um, causes, the toxins. And these toxins can be really toxical substances, like for example some antibiotics, which degenerate the tubular cells, or artificially given substances like contrast media for radiological investigations. Um, this is the so-called contrast nephropathy, the contrast media nephropathy, which is a huge problem in medical interventions. And basically, we can say it's kind of like a iatrogenic cause of acute kidney disease. Um, and it counts for a significant amount of the patients. And what is the major problem with acute kidney disease? If it develops, we lack of effective therapy. So basically, the mortality in intensive care unit treated acute kidney disease patients can be up to 80%, which is extremely high. It's very, very high. And basically, the lack of effective therapy is also due to the lack of effective early diagnosis. And this is what I told you already in the previous, in the one of the first slides, that the classical creatinine urea levels that are in the definition of the diagnostic criteria of acute kidney disease will not increase at the beginning. So if you are a few hours after the kidney injury and the kidney is already injured and the kidney function is already decreased uh, dramatically, still the blood creatinine and urea levels will not start to increase. So there is a window where you cannot clearly um, um, see what's going on in the kidneys just based on the kidney function parameters. And that's the main cause why the treatment is also problematic. um, what about the pre-renal acute kidney disease? So this is due to hyperperfusion, so blood supply problems. uh, One of the problems could be a one-sided renal artery stenosis, which will also affect one of the kidneys and the other kidney remain normal. However, if you hyperperfuse one of the kidneys, the hyperperfused kidney will immediately start renin secretion. So there will be a renin overactivation. This will induce angiotensinogen, angiotensin uh, conversion, and aldosterone release. And altogether, this activation of the renin-angiotensin aldosterone system by one of the kidneys will lead to systemic hypertension. And the systemic hypertension, uh, first of all, will not increase too much the perfusion of the affected kidney, because if there is stenosis, the hypertension will not help too much, but it will harm the other normal kidney. So the other side, which was previously healthy, will get hypertensive nephropathy damage. So there will be um, a complete two-sided kidney damage at the end, and the chronic kidney disease, which will lead to end-stage renal disease. So therefore, the early um, um, diagnosis of such problems like one-sided artery stenosis and the resolution of the stenosis is essential for the survival of the patient, and also to protect the other kidney. Where the circulatory shock, you may remember, is a bilateral kidney injury, because the circulatory shock, of course, is a systemic problem. There will be systemic hyperperfusion. In proximal tubules, the hypoxia will lead to acute tubular necrosis, and this is the main problem that we will discuss a little bit later. And of course, there are some surgical causes, like, for example, major surgeries, cardiac surgeries. Well, for example, you have to stop the heart beating and actually try to lower the blood pressure as much as possible. Temporary clamping of the renal artery, because you are operating some kidneys, for example, resection of some tumors, and you have to clamp it for half an hour, for example. And of course, the local hyperperfusion will have the same effect as here. Um, how can we differentiate between a renal cause, so intrarenal, and the prerenal acute kidney disease? In the kidney practice material, you will see the same equation, the same formula. And this is very important, because this is something that we can use in the clinical practice easily and is very cheap. And actually what we can use is the calculating the fractional excretion of sodium, um, because if the fractional excretion of sodium is below 1, then it's a prerenal acute kidney disease, which means that due to the hyperperfusion, the kidneys cannot excrete sodium. That's just to make it very simple. If there's an intrarenal acute kidney disease, the tubules are not able to reabsorb sodium because of the tubular damage. So the filtrated amount of sodium, most of the filtrated amount, will just go out into the urine. And that's why the fractional sodium excretion will be over 1. Okay, just to make this formula very simple. So if there is a tubular damage causing acute kidney disease, then there will be loss of sodium. If there is hypoperfusion of the kidney, there will be basically mostly sodium reabsorption in the tubules, and the filtrated amount of sodium is lower. Okay, that's why this number is below 1. The other parameters can be checked as well, but actually this is the most important that can easily differentiate between these two entities. What can cause intrarenal acute kidney disease? Uh, for example, energetic nephropathy. Energetic nephropathy nowadays is an increasing problem, because it will cause an irreversible um, uh, necrosis in the renal papilla, which of course needs a renal replacement therapy. And it will be a bilateral problem, because both of the kidneys will be affected by the same systemic drug administration. This pathomechanism is based on the non-steroid anti-inflammatory drug overdosing. So those patients who can freely buy NSAIDs and take 1.5, 2, up to 3 grams per day, due to their chronic um, other chronic diseases, like, for example, rheumatoid disease, um, um, with chronic pain in the joints or whatever. So this is the most typical problem here. These patients, first of all, will get severe gastric problems due to the same process, so inhibition of the prostaglandins. But in the kidney, the inhibition of prostaglandins will lead to constriction of the vas afferents in the papilla, because these are the substances that can um, influence the dilatation of the vessels, and the chronic constriction of these tiny um, um, vessels will lead to severe hypoxia, and this will lead to necrosis. And if you remember the first slide where I showed you that what is the oxygen saturation when you go from the cortex towards the papilla, you could see that it's normally also physiologically much lower in the papilla compared to the cortex. And if you even to these vessels um, make an extra vasoconstriction, so this will kill basically the cells surrounding. So that will lead to papilla necrosis. Toxic causes are also seen. This can be related to medical interventions, for example, aminoglycoside antibiotics like gentamicin. This is toxic for the tubular cells, and this will kill the tubular cells, or um, accidental ingestion of, for example, antifreeze um, substances like ethylene glycol. This happens mostly in children or in adults only if they want to commit suicide, and they try to do it with some substances like that. Actually, it's a very bad idea because the patient will not die but will kill the kidneys um, um, effectively. So we'll need renal replacement therapy after that, and the contrast medium-induced nephropathy that I told you before. What is the mechanism of this intrinsic or intrarenal acute kidney injury? There is an injury phase and a resolution phase. Actually, in the injury phase, there will be tubular cell damage as the hallmark of what's going on. There will be some inflammation as well, and you have to get rid of the debris of the dead cells, of course, and there will be also vascular damage. In the resolution phase, the stem cells try to the mesenchymal stem cells try to go to the side of injury and try to normalize the structure. As long as the tubular basement membrane is intact, there's a good chance to repopulate the dead, um, the site of the dead tubular cells with newly differentiated tubular epithelial cells. So the recovery capacity of the renal tubular system is quite good and quite high, um, as long as the basement membrane is intact. So there was no extremely severe damage to the basement membrane. What is the epidemiology of the different severities? Sorry for the quality of the slide, but that's the best what we could find. Actually, you can see that if we differentiate between the severities based on the increase in serum creatinine, uh, the milder uh, um serum creatinine increased cases are the most common. It's approximately 30% of all the cases. But here's the lowest the mortality. So these are the patients who have the best chance for complete resolution. However, those which have an extreme increase in the serum creatinine very fast have the highest mortality rate. So they have a 16-fold chance to die soon as compared to the healthy population. So that's basically what why we have to try to catch the acute kidney disease in early stages and try to do something to treat them. The complete survivor, yeah, well, this is also similar. So here you can see that based on the rifle and the Akin classification, you can see the same basically survivals. The compared to the no kidney damage, basically the survival rates for the stage 3 or here the very advanced stage are the worst. What does hypoxia do? Actually, the tuber interstitium is first damaged, and here you can see that due to the lack of oxygenation when you go deeper, and the fact that the osmotic concentration is continuously increasing, Basically, these cells are very susceptible here in the deep medulla, in the inner medulla, are very susceptible to injury. Although here there is no um, extreme ATP need, so these cells are not making such active transport as the proximal tubular cells. In the proximal tubular cells, basically the problem is that although the oxygen saturation is relatively better and the um, extracellular osmolality is also more favorable due to the lack of ATP in case of hypoxia, these cells will get damaged very soon. So actually what happens is due to toxic and tubular injury is a tubular cell necrosis. And the term acute tubular necrosis, for sure you have already heard many times. Acute tubular necrosis we talked about with the shock as well as a typical histological feature of shock kidney. And in the pathomechanisms, there are several factors. First of all, the so-called tubuloglomerular feedback mechanism. The problem is that there will be a continuous filtration through the glomerulus because the tubules are damaged and not the glomerulus. So first of all, please remember, in hypoxia and toxic injuries, not the glomeruli are damaged. The most damaged compartments are always the tubules. This is the most sensitive part. The glomeruli are not so sensitive. They are not using up a lot of oxygen. So back to the fact that there is a continuous filtration in the glomerulus because this remains healthy. But at the same time, there is a problem in the tubular system, and there will be abnormal resorption in the proximal tubules. This will increase the sodium chloride in the macula densa, and this will activate the renin-angiotensin system that will decrease the GFR to some extent. But there is also a problem that due to the inflammation mostly and lack of tubular epithelium because of the necrosis, there will be a back leak mechanism here. So the filtrated fluid, parts of the filtrated fluid, will just leak back towards the interstitium and to the vessels through the damaged tubular walls. There will be, of course, a lot of apoptosis. These apoptotic cells will go into the lumen of the tubules, and if a lot of dead cells are in the tubules, they can also lead to an obstruction because they will precipitate together with the proteins, etc., and form obstruction of the tubules, as well as there will be obstruction of the peritubular capillaries. And the peritubular capillaries will get obstructed mostly because of excessive leukocyte infiltration. And I will show you a slide about that later. And there are, of course, other factors as well, like epithelial cell damage together with endothelial cell damage, and altogether the inflammation. Um, Ischemic acute kidney injury is mostly caused by the hyperperfusion we already discussed, the greater surgery, septicemia, and mostly in patients with the comorbidities that we discussed before. What are the steps of the Pacto mechanism? Actually, ATP depletion is very important. At the same time, the ischemia will induce inducible nitric oxide synthase, and due to the fact that the produced NO will, due to the fact that there is no ATP and there is no available NADH, the generated nitric oxide will get oxidized, and there will be peroxynitrate formation that is a very um, active metabolite, oxygen radical as well. So it will cause oxidative stress, oxidative injury, and protein nitrosylation. Of course, the lack of the ATP will have also some mostly direct effects. Will alter the cell membrane, and this will lead to the possible swelling of the cells, and they will just explode or just get injured. degradation of the cytoskeleton, and it induces the apoptotic and necrotic program as well. And the different phases of the tubular cell injury can be seen here. It's kind of circle where from the normal epithelium the ischemia will first of all present in loss of brush border, and this is what we see in a proximal tubular cells, that loss of brush border. It's a very important feature in the histology, showing that these cells are injured. Then some of the cells will necrotize and apoptotize and then just go away, and there will be some leaks between the epithelial cells. But usually there is also some viable cells that can proliferate after the differentiation, and this is what happens. So they will just switch their phenotype to a stem cell like phenotype, proliferate, and then repopulate actually uh, the the tubular epithelial wall, basically. But this only happens so long the basal membrane is intact. In the histology of the acute tubular necrosis, this is what we will see as the most important feature: the loss of blood border in the tubular, proximal tubular cells, and of course the presence of proteinuria, which will be seen as hyaline cast. And this is what you can see in the histology, that compared to the normal cortex and medulla, in the injured cortex, you will see no brush border. This is the brush border here, is a periodic acid Schiff positive. This is last year. The cuboidal cells change their morphology to flat cells. There will be, this is the so-called tubular dilatation feature, and here in some of the tubules you can see the hyaline casts also as a feature of the massive proteinuria. And macroscopically, this is what we can see, that there is basically infarction in many parts of the kidneys, and there is apoptosis, a lot of apoptosis. These brown cells are all undergoing apoptosis. So um, this is what happens, and basically the apoptosis is induced by two features: either a mitochondrial intrinsic feature or an extrinsic receptor mediated. The receptor mediated is bound to the immune system, so you need a fast ligand connection to activate the caspase 8, and this will further converge on the caspase 3, and this leads to apoptosis, just to make it very simple. And the intrinsic uh, mitochondrial damage will also start um, the apoptotic program via caspase 9 and then converging to caspase 3. Uh, this is another picture showing the tubular cell descosis, just summarizing the hypoxia, loss of ATP, oxidative stress, inflammation, activation of the complement system, toxic substances, complement components, for example. That's also maybe interesting. For example, the C3 complement component C3 has receptor in the tubular cells. So basically, if the complement 3 gets in contact with tubular epithelial cells, it will activate its receptor, and this can also induce apoptosis of the cells. And in the peritubular capillaries, basically there will be this obstruction that was mentioned a few slides before, and this is caused by the activation of the endothelial cells. They will start to express selectins and ICAM molecules, which will recruit basically the leukocytes, plus the endothelin 1, which is released from the injured endothelial cells, will cause a constriction of the vessels, and the local infiltration of the of the inflammatory cells will further cause a progression, because the release pro-inflammatory cytokines will further activate endothelial cells, plus there will be oxidative stress, which further injures the cells. And the end will be, of course, a clotting induction as well. So there will be a massive obstruction of these peritubular capillaries that basically causes the infarction that we have seen in the macroscopic picture. What are the clinical symptoms? Clinical symptoms are usually the decrease of the urine volume, which could be oliguria at the beginning, and it can also progress to anuria. Less than 200 milliliters per day is anuria. Retention, which will be first seen by increased edema, generalized edema, and later increases in serum creatinine and urea level, as well as increase in serum potassium level. And basically, these patients need hemodialysis basically within 1-2 days. Um, the stages of this kidney injury are the injury stage, the extension, and the repair stage. I told you that basically the early diagnosis would be essential, but we lack of early diagnostic tools if we only rely on the serum creatinine, because basically the serum creatinine and urea start to increase significantly 3 to 4 days after the onset of the acute kidney damage, which means that if you realize that your patient has already underwent acute kidney damage, you are over the therapeutic window. You cannot do anything else, just start a hemodialysis and wait and pray, basically. Um, but if you could catch it in the stage one, basically, and not stage 2 and 3, then you would have better possibilities to treat the patient. Um, and basically, it's also seen that in case of an early diagnosis in stage 1, the mortality of these patients significantly drops. So it will not even reach the 30% that we have seen, 40 to 80% in intensive care units. Um, what to do? So there are new approaches for that to use as diagnostic biomarkers in kidney disease patients, and these are rely on tubular enzymes, because mostly the tubular cells are damaged in acute kidney injury, and these are released from proximal tubular cells within 12 hours and many days earlier as creatinine increases. For example, proximal renal tubular epithelial antigen 1, gamma glutamate transpeptidase, lactate dehydrogenase, N-acetyl beta glucosaminidase, alkylic phosphatase. So these can be checked from the urine as well. And also low molecular weight proteins in the urine. If you remember the microproteinuria term, uh, these show very early that the proximal tubular cells are not able to reabsorb the microproteins, the serum microproteins that were filtrated. So the beta 2 microglobulin can be checked from the urine as well. Increase in beta 2 microglobulin levels in the urine is a bad prognostic factor. And cystatin C is also increased. This has been used as a new method for a GFR estimation as well. But the problem with these uh, biomarkers is that they also increase in the urine when there's a reversible or just a transient mild dysfunction. So they are not specific for acute kidney disease. A little bit better parameter would be the neutrophil gelatinase associated lipocanin, or NGAL, in the urine, which is released by the tubular cells after ischemia in a vast amount, and basically it is released by the cells because it has a protective effect on the cells itself. It inhibits apoptosis and induces proliferation of the healthy tubular cells, and also it can decrease the oxidative stress via hem oxygenase activation. So this is kind of a protective response of the tubules upon damage. And basically, the increase in NGAL level can differentiate between the perirenal acute kidney disease and the acute tubular necrosis, because if it's acute tubular necrosis, you will see much higher levels, and the sensitivity is over 70% if we take it 3 days before the diagnosis of the classical diagnosis of the AKD. So, which means that When the serum creatinine is still not increasing, the sensitivity is over 70% if you check angle. And there's another biomarker which can be checked from the urine, the so-called kidney injury molecule 1, which is a type 1 transmembrane glycoprotein, and it is overproduced in the proximal tubules in case of an ischemic acute kidney damage. And there is also available dipstick tests for point of care diagnosis, which is very good and very fast. And basically, also we have the possibility to check the plasma levels of neutrophil gelatinase associated lipocaine, but it's not as sensitive as the um, urine measurement. Of course, if you cannot get urine sample because the patient is already in anuric phase, then check the blood. Other biomarkers in the urine that can be used are renin to creatinine ratio, angiotensinogen to creatinine ratio. That's not very much used in the clinical practice, but also there is another dipstick test, which is a so-called nephrocheck, which uses two proteins, the tissue inhibitor of metaprotease 2 and the insulin-like growth factor binding protein 7, which are released into the urine when the patient has acute kidney disease. And basically, it works like these pregnancy tests. So they just you you put the sample on top of it, wait a couple of minutes, and you will see bands of positivity or negativity. And now let's talk a little bit more in detail about some diseases like the glomerulonephritis that we already talked a lot about. And basically, the clinical symptoms of glomerular damage can be either nephrotic syndrome or nephritic syndrome. As most of the students mix this up in the exams, and this is very good to clear the terms because it's a little bit different. Nephrotic syndrome has a major feature of generalized edemas and proteinuria. The most important here is a massive proteinuria that leads to edema. Okay, so there's a nephrotic syndrome. In nephritic syndrome, there is milder proteinuria at the beginning, and the leading feature is the glomerular hematuria. So that there is glomerular damage, allowing red blood cells to go through. And of course, here we have at the same time endothelial, GBM, and podocyte damage. Of course, we have mixed forms, just to make it more simple for us. Mixed forms can be seen usually in patients who have a disease for a longer time, so then the damage can progress. The most important causes are autoimmune, actually. And this is the comparison, the most important feature comparison of the both nephrotic and nephritic syndromes. Here you can see that, and we will talk about that a little bit later, but here you can see that some of the patients have the mixed form. What is the typical feature for nephrotic syndrome? Edemas in the legs, in the periorbital region, albuminuria, foamy urine sample, and severe hypoalbuminemia, which increases the plasma LDL concentration. This is typically what we see in chronic kidney disease patients. The most important causes are minimal change disease, mostly in children. This is in children. Diabetic nephropathy in adults, hypertensive nephropathy in adults, and focal segmental glomerulosclerosis, which can be a consequence of primary forms or secondary due to diabetes or hypertension. And let me just show you two case studies as well. One of the case study is a young man uh, incidentally seen a foamy urine after flu vaccination and has polyuria and has nicturia, so urination in the evening. And edema developed, which improved after diuretic administration. The GFR value was still normal. After a half a year, the GFR dropped by 50, more than 50-60%. So down to 30 milliliters per minute, which is already very dramatic. And of course, a biopsy in this case is essential. So a kidney biopsy was done, which shows glomerulosclerosis, fibrosis, and tubular atrophy. And the electron microscopy shows that podocyte food processes, which should be healthy like that here, are fused in many parts over the filtration barrier, and this fusion of the podocyte processes is typical feature of podocyte damage, and the overall diagnosis was a focal segmental glomerulosclerosis. The complications of the nephrotic syndrome is increased atherosclerosis due to the high LDL, thrombotic features, and of course, this can lead to cardiac problems and acute myocardial infarction. The treatment is usually immunosuppression at the beginning and against complications, reducing the lipid levels and avoid the traumatic events. Uh, um, we will talk about this later. Why immunosuppression is basically what we have to use in nephritic syndrome. Basically, the most important causes in adults is IgA nephropathy or membranopproliferative glomerulonephritis, or some feature of a systemic autoimmune disease like SLE or rheumatoid arthritis. In children, however, the post-streptococcal glomerulonephritis is the most common, and probably you already heard about that in microbiology when you were learning the streptococcal strains. There are so-called nephritogenec strains which can cause this glomerulonephritis. And this is a typical picture of urine sediment in case of a dysmorphic red blood cells compared to the isomorphic normal red blood cells. So this is the glomerular hematuria that we can see here, and massive hematuria, macroscopic hematuria can also be present. And here's a second case study showing a soldier, a young man, who was at routine medical examination showing proteinuria and microhematuria, which means that microhematuria means that only seen in microscopy, so dysmorphic red blood cells. And in the history, he had vasculitis in the legs, but after corticosteroid treatment, there was a remission. Serum IgA level was slightly increased, and the possible diagnosis, because he had vasculitis and IgA and hematuria, was the Scheinlein-Henno purpura as a differential diagnostic problem. However, although this disease is typically beginning at young patients with IgA immune complex mediated systemic vasculitis, and it can damage the kidneys, still there is a good prognosis, and usually the serum IgA level doesn't increase. But when the serum IgA level is increased and there is a kidney disease, you have to think about IgA nephropathy. And basically the kidney biopsy shows actually IgA deposition in the mesangial region and IgG deposition and basically a fibrosis. So IgA nephropathy was a diagnosis. So what is IgA nephropathy? IgA nephropathy is the most common primary glomerulonephritis in adults. Okay, and the main findings are the proteinuria with massive glomerular hematuria, and usually there are increased serum IgA levels detectable. It can present as acute or chronic disease, mostly, of course, acute onset, and this will lead to chronic disease. And 25% of the cases leads to the end-stage renal disease, so CKD. There is mostly a male predominance with genetic background bound to HLA-DQB1 allele. These patients have a six-fold increased relative risk. And it's very interesting that most of the patients tell at time of onset, just before the onset of the disease, they had a respiratory tract infection, so some viral inducer cannot be excluded. And these are the symptoms that basically we already discussed. Another problem of glomerulonephritis is the systemic autoimmune diseases, as you have seen. And basically, lupus nephritis is a known feature of systemic lupus erythematosus. About 50% of the patients will develop lupus nephritis, which shows a type 3 hypersensitivity reaction with immune complex deposition, so complement and IgG deposition together. You can stain also the kidney biopsy specimens for C3, complement component 3, and IgG. They will show the same location. And there is also active inflammation. You can see that the kidney biopsy shows a massive lymphocyte infiltration. It looks more a spleen like a kidney. and hyaline cast due to massive proteinuria, and basically the majority of the glomeruli will get injured, and you will see the mesangial proliferation, and some of them will get total fibrosis. And this leads to chronic kidney disease with acute relapses. And as last disease, basically the post-streptococcal glomerulonephritis, and I left it to the last because usually this you will not see in adults, although it's very important in children, because the nephrogenic streptococcal strains, as they can induce due to the molecular mimicry, they can induce autoimmunity against self connective tissue. Several organs will be damaged. Very, very important is the myocarditis that can develop with the glomerulonephritis that we were talking about. And this can also lead to arthritis, systemic arthritis, and vasculitis. So in total, post-streptococcal glomerulonephritis patients mostly also have other organ manifestations at the same time. And the renal onset usually happens weeks after the infection, which means that these patients are in an autoimmune state and they have to be treated as autoimmunity, which means with immunosuppressants, not antibiotics, because you cannot even detect the bacteria anymore, usually at the stage when the glomerulonephritis develops. And this was the last slide. So thank you for your attention. And I apologize if it was a little bit too much, but actually the topic is too much. And if you have some questions, just please ask me.